right, folks, so we're going to go ahead and get started. We call this the Survivor Session, so really appreciate you all being here today. At the end of the day, an opportunity for us to do some wrap-up, continue the dialogue. I was in many of the breakouts. I hear a lot of engagement, and so this is our chance to sort of keep the conversation going, but also come back to anything you heard during the day. So I have the pleasure of introducing our speaker for this closing session. Dr. Fotinos is the Medicaid director. Are you also still the behavioral health medical director as well for HCA? And in that role and in those roles, you've got a lot of things in front of you. I know we've talked about some of them throughout the day. So what we're going to do is go ahead and have Dr. Fotinos give you her thoughts, and then we're going to take Q&A or follow-up or commentary from you all and take it from there. So I'll let you go ahead.
Excellent. Are you able to hear me? I won't mess with the microphone and then I won't stutter. Excellent. And I see people yonder and far, so I can't see faces, so you can make faces back at me. I can't see, so it doesn't matter. So thank you for staying. I think, as I was standing at the bottom of the stairways, I was looking at the sort of state of reform, bridging the gap between healthcare and health policy. And I started my career as a family physician. And at that point, in my mind, I was in my late 20s, and healthcare was office-based or hospital work. Healthcare was, how physicians are trained to deliver health, in my mind. And the conversations today are very different. Healthcare is not just about the delivery of medical services, though that takes up the most money and the most attention and the most focus. We now talk about healthcare being about prevention, about housing, about food security, about safety, about community. And that's not a new conversation for public health, but I think it is a relatively new conversation for particularly providers in healthcare. So I think just the evolution of how we think about and talk about healthcare has been interesting to watch over the 30 years. And then I thought, well, health policy, what does that mean? I am in a role where I help with a tremendous team and many partners, some of whom I see out here, we work on health policy. And what does that mean exactly? Is that state level policy? Is that institutional policy? I think it's all of it. Is policy a decision to do something different? So I think, and in listening to the different talks today, what I've heard is that it is clear that healthcare, broadly speaking, is local, and that the challenges that folks on this side of the state face, while the problems, fentanyl epidemic, overdoses, housing insecurity, food insecurity, are the same. People with complex mental health and physical health conditions and substance use disorders, you can find those in any pocket of the state. Go anywhere. Folks are living with them, or have people in their family who are. But what's different are the resources, the attitudes, and the vehicles that each region has to bring to bear. And so what I heard today were some really bright, passionate, talented people talking about solutions that they've brought to bear. And usually these conferences just make me tired because there's a lot of stuff that we can do better on, but I actually heard positive things. I heard that the conversations about housing today are not just among housing providers. That's very different. I heard, in the housing, they've been talking about braided funding for 20 years. Why don't we have that conversation in healthcare? We don't braid funding. It's very distinct. We have Medicaid funding, we have block grant funding, we have commercial payers. But in the housing world, they figured out coordinated entry and braided funding is the only way we're going to help people broadly. So to me, that's a conversation that we haven't yet had, but we might need to. How do we expand the way in which we think about healthcare in that more braided, no wrong door approach? So I think those are just some of the reflections that I've had today, listening to the different conversations, and I would be very remiss to sit up here and pretend that all the work of the Healthcare Authority, I get to be the spokesperson for it, but I can honestly say that I've worked a number of places in my career, and the group of folks that I work with at the Healthcare Authority are passionate, they're dedicated, they're talented, they're relentless, they're overworked, they're underpaid. And at the end of the day, all they want to do is implement policy and programs that make people's lives better. We don't make everybody happy. We rarely make anybody happy. But the folks that I have the pleasure of working with are all in. And I think those of you who have the pleasure and opportunity to work with them know that. And so I think that is a special and very gratifying position that I get to sit in and be in, because it's easy for me to talk about the work of the agency because I believe that the mission of the agency and the spirit of the agency is in moving forward the health, broadly speaking, of our communities. So I just wanted to say thank you to all of the folks who I have the pleasure of working with in the Healthcare Authority, and I see a bunch of great partners from the community out there as well, so I want to share my gratitude. You heard in some of the sessions, if you participated in some of the initiatives that we're doing at the Healthcare Authority, and I'll mention a few, but I would really rather this be a conversation rather than me just sort of, chatting about all the things. And as I had the opportunity to go around to different team members yesterday and ask them what they're doing, I filled up about a page and a half of activities. And I could read those to you, but I don't think that I'm going to. Not because they're not important, but because I'm not sure at the end of an interesting day that would do anything other than overwhelm you and make the people who are working on those things even more tired than they already are. But I think there are some themes. I think there's some themes in the work that we're doing. Certainly, priorities for our agency in this next year are continuing the public health emergency unwind. I got something in my email box about how healthcare emergency unwind is an absolute disaster. People are losing coverage. 6 million people have lost coverage. We know in Washington that's not the case. We know that a number of people who were covered during the public health emergency have lost Medicaid coverage. The vast majority of those folks never used services and never updated information once they enrolled in Apple Health. We knew that the first 3 months of that public health emergency unwind, May, June, and July, we would see a lot of people leave Medicaid because they'd just been enrolled and never really updated any of their information. And we know that going forward, we went from about 80,000 people losing coverage. In August, I think we're down to 17,000. So the good news there is we predicted that right based on the history of utilization or non-utilization of the people who've been kept on Medicaid for the public health emergency. So we need to stay vigilant. We need to make sure that if someone does lose coverage, they know that they can re-enroll. They have up to 90 days to re-enroll. We have our managed care plans doing great outreach, trying to find their members if they are disenrolled and get them re-enrolled if it's appropriate. People are being transitioned to qualified health plans or other coverage if need be. And this is not just a Healthcare Authority effort. This is DSHS, this is the Health Benefit Exchange, working closely in partnership to make sure that at the end of the day, people who are able to get coverage of any kind have it. And so I think that remains an important focus of ours, that we will look monthly at how are we doing? How are we doing if people are being lost to coverage? Are they getting back on? Are we making sure the people who should be covered stay covered? I think the other big piece of work coming up is the development of the Apple Health Expansion Program. We were funded in the last legislature to fund a program that mirrors Apple Health for people who are otherwise not eligible for government-funded insurance. And so we have a finite amount of money to fund that, and that's a lot of details. Working closely with community stakeholders. Arguably, there's always more community to work with, more information to be had. And I know that is a priority of a number of legislatures, our staff, and others. So that's a huge project that we're working towards as well. The other piece is the Medicaid Transformation Program 2.0, our second version of the waiver. For those who were in the session earlier, there's a ton of work in that, and it's exciting work and it's good work. We'll have reentry services for justice-involved individuals. We'll have coverage of different health-related social needs. We'll continue some of the programs, foundational community supports, with additional benefits. So that is a huge amount of work that we will need to staff up and work both with our federal partners as well as you all to help us figure out what's the best way to implement, measure, and track these programs so that eventually, if through waiver authority they show benefit, we can move them over to regular Medicaid services. We continue to partner with our 5 managed care plans in really helping to take the funding that we receive from the legislature and the federal government and deliver health services to folks. We have still our fee-for-service population that is largely our clients who are duly eligible, as well as folks who are tribal affiliated or tribal members who are not part of managed care plans. And I think one of the things we're very interested in is how do we better support that group of folks? Because they don't have the same care coordination, case management support that people on managed care plans do. So how do we think about that from a disparity perspective or an equity perspective and figure out how to better support that population as well with different needs, but still complex health and behavioral health needs. So I think that is also a focus of ours going forward. How do we assure that people have access to the same type of supports across all of our programs? We could spend an entire day talking about the needs in behavioral health and all the work in behavioral health, whether that be through mental health, development of the crisis system, the need for more acute crisis beds. But I'm a primary care doc, I'm a family doc, and prevention, early intervention, early identification. We can't lose sight, even though what we see and are most affected by, and I'll say that personally, it's hard to ignore someone who is sleeping in a doorway or someone who is bent over because they just used fentanyl and are asleep, for lack of a better word for that. You see that and you sort of focus on that, but we also have to think about how do we prevent and identify people early who may be struggling. How do we provide them services that aren't deep end? They're not crisis. They're time-limited, focused services that we heard about some programs today, behavioral health aides. How do we move upstream to really prevent people from getting to the point where the crisis is all we see and all we're responding to? And I think that's a challenge. We don't have answers for that. But I do think that's an important piece as we go forward. But the fentanyl crisis, I would be remiss to not echo what I've heard everyone say today. I had the pleasure, I think with some other folks in the room I see, who were invited to the National Tribal Opioid Summit. That was, I think, last month for a couple days, and there were tribes from all over the country. It was the first National Opioid Summit hosted by some of our tribes here. It was honestly a hard couple days to listen to because we heard stories of 10-month-olds who had died from fentanyl exposure. We heard about kids who'd been to more funerals than birthday parties. And the disparities and the impacts in communities who are already at a different advantage is no more stark, I think, than among our Native American communities, which is not to say it's limited to that, but it was hard to listen to and also hopeful because the resiliency, the traditional culture, the community with which Native cultures are driven, and the history and the knowledge that they have, if anyone is going to figure out how to address this from a community health perspective, it's going to be the tribes. And so I hope as an agency and as we go forward, we can learn and listen from them. Because I think we have a lot to learn from our tribal partners and tribal governments that we are partners with. So I'm going to stop there. Again, I could list a litany of work, but I would rather have a conversation.
I totally agree with that and look forward to the questions. You know, I wanted to first remark on your point about how we define policy, because to me it is certainly public policy, which is where we often go. We think about it as legislation or regulation, program rules. But there's also organizational policy, which is many of us have a direct role in as well. And then I think your point about sort of the mental model, the community policy and expectations, I think are really important. And that means we all have a part to play in this, even if we're not a legislator or we're not doing something along those lines. We have policy that we have influence over as individuals in different organizations. So I think that's a terrific framing. And also the optimism, right? Because these are designed to give energy, not to feel like, yeah, I already knew about that problem, but really to talk in a creative way. And so I appreciate those comments.
Yeah, and I think while people are getting their questions ready, and I have no shame calling on people, and I know a number of your names, so I will not be shy. But I think I really have to shout out the last session I was in, which was the housing session, and I see Rhonda, and I came in late, so I didn't hear the other speaker's name, but I heard some really great pearls that one, which Rhonda Hoff shared, was vulnerability is in the handoff. And I think that's really important. And I heard throughout that housing talk mention of continuum about 10 times. And unfortunately, I think we are, and I'll use the word victim, that's kind of laden, but we are dealing with the consequences of a health system that grew up without any sense of coordination or continuum. Somebody has a heart, people have heart problems, let's build a heart hospital. People have stroke or neurologic problems, let's build a neurologic hospital. Let's build a behavioral health thing that only takes care of mental health but not SUD. Let's build SUD. We've specialized to the point of not being able to talk to each other or have shared conversations about the needs of the person. And what I heard that we could learn from the housing world is they are figuring that out. And the other thing I heard that I've been thinking about a lot lately is government cannot fix all of this. Medicaid cannot fix it. Medicare cannot fix it. That we have a ton of money in this state. How do we engage not-for-profits? How do we engage the community, the big business? How do we engage people and make this part of their shared responsibility to their communities and their workforce to subsidize housing for their middle-income workers who can't afford to live in the cities where they work? So I think that the other thing that struck me is we've got to broaden our conversation. No one wants government to do anything, but we try really hard to be helpful, and we cannot fix these problems on our own. And so how do we develop the narrative or the frame so that when we're talking about housing instability, whether it's in Ponderay or my neighborhood in Seattle, folks are impacted the same way. They don't have a place to sleep at night. And the landscape is different, but the problem is the same, and the impacts on that person's family and their lives are the same. Why can't we figure out a way to have that conversation so that we're addressing the need of the person and not, political, regional? I thought that was really striking. I think there's a lot to learn there and a lot of opportunity.
So I'll turn it over to you all. What did you hear today that you want some follow-up or feedback on? Any ideas to share?
I do know your names.
So you got it all. Oh, good. We have a question. Right here. You got a mic coming. Just a second. Yep.
Angie Sparks, United Healthcare, Chief Medical Officer. Thank you, Dr. Fotinos, for doing this talk. We really do appreciate hearing from you always. As I was looking at the Medicaid 2.0 waiver 115, I was thinking about how much is in there for adults. And adults are a lot of them are parents, and so there are some effects on the 0 to 5 age group. But we have talked about kids in some of the sessions and how this will benefit them. So as we're thinking about that vision that comes from all of the new things that we're going to try with the waiver, where do kids fit in? How do we address that?
Right. So I think, one of the things that I think is always a challenge in these types of conferences is what they're focused on is a slice of the pie. And so today, the Medicaid transformation waiver largely, but not exclusively, focuses on adults. A big piece of our agency's work has been and will continue to be in that early 0 to 5 space. We have continuous eligibility now for 0 through 5 years old, which is a start, but just having access to medical care doesn't mean that you can access it or that you have access to all the other pieces that you need. Jason and myself and Beth Tinker from our agency got to spend, I think it was Tuesday, with the Washington Academy of Pediatrics doing sort of a strategic planning session focused on birth to 3 years old. And I think that part of our challenge is we know that if we don't help infants and early childhood relations develop with their parents, caregivers, guardians, whichever it may be, if they're not able to develop healthy reciprocal relationships, then the stuff that we see in adults can't be avoided. It's not going to get better. We have generational cycles of poverty, of addiction, of other things. And so how do we set little ones up for success? How do we get them school ready? How do we provide the supports they need so that when they get to be teenagers, they have a foundation to make a better choice than they might otherwise, or they know that they have the option of a choice. So we continue to do a lot of work in that space. We have built out our infant mental health screening and policies. There's a lot more to do, but to your point, Angie, we have to really focus, again, sort of that upstream. Is in a way, you know, we are attracted to the flashiest, noisiest thing in the age of social media, and our attention span's about 30 seconds or however long TikTok is, right? So we see that, we're like, oh, that's a problem, we gotta fix it. Yet sort of that undercurrent of unstable but not yet screaming for help is easy to not see. And I think you raise a really important point that yes, there's all this, but unless and until we make sure that we pay attention to what's foundational and most likely to help people be successful, we're going to keep just responding to the chaos and the noise. So I think it's both and.
Thank you, Dr. Sparks. Other questions or comments or issues? I have a quick question, actually. You did really well at forecasting so far the disenrollment situation, and I hope you are able to maintain those lower numbers. Mm-hmm. What do you see as the likely enrollment for the new program for undocumented or otherwise ineligible?
You know, I think that's a good question. We are still in the processes of planning what that will look like. As many of you may be aware, we are able to receive some federal matching funds for certain conditions that people who are not eligible for federal programs qualify for, so like dialysis, acute cancer care treatment, acute emergency services. So we want to maintain our ability to leverage that federal funding. So how do we think about that group of people who are currently receiving limited but benefits that are federally matched? How do we think about transitioning them to this new program or making it available to them versus having other people sign up? So the program was funded partially, but it is likely not funded at a level that will meet the need. So a lot of the conversations that we're having now with our partners in the community and other state agencies is how do we do this in a fair way that doesn't, knowing that we have a finite pot of money essentially. So I think a lot of it is trying to figure out what's the best way to think about and approach that, make sure that we can leverage the federal dollars when we are able to do so, and see how the legislature decides to move forward in the continued funding or expansion or not of the program.
Thank you.
And I would just caveat this, if all of you guys sitting here at the table disagree and have something to correct me, please say, no, I'm good.
Don't always get that chance, right?
Yeah, that's right.
Okay, terrific. Last chance. Oh, here we got one back there.
We'll give it a go. You said you were a family doc, mm-hmm. and you believe in primary care. And 2019, the legislature said that they supported primary care investment to the tune of potentially 12%. And yet, if we follow what the rest of the country has done post-COVID, we've probably gone in the wrong direction, though those numbers I don't believe are in yet. What can we do as a community to move primary care investment forward?
That is an excellent question, and you reminded me of one of the things that I didn't talk about. I think, I think that there was a report earlier this week, I can't remember if Commonwealth Fund or Kaiser Family Foundation put it out, sort of where we are in terms of people getting care from primary care specialists versus primary care providers versus specialists. And the pendulum was really more people are getting care from specialists than primary care. And while in the short term, if you're having a heart attack, that makes sense. In the long term, that's not a sustainable healthcare system. That's not a foundation that will keep care available or access open to everyone. I think not just because I'm a family doc, but because just thinking about my past relationships with patients, listening to the folks from the FQHCs today talking to my friends who are still doing clinical medicine, there is something about that relationship when people are able to develop it with a primary care provider, whether that be a nurse practitioner, a physician, a physician's assistant. It doesn't really matter, but that provider relationship, there's something really special and important about it. And I think what we've also learned over the last number of years is that the delivery of healthcare services is not a individual to individual task. It's a team-based effort. And the more needs that people have outside of the physical and behavioral health sort of things that you can prescribe a drug for, the more of a team we need. We need community health workers, we need peers, we need patient navigators, we need promotoras, we need doulas. We really need to expand how we think about not just health, but the delivery of healthcare in a way in which people are comfortable. One of the things that we are going to be engaging in is a CMMI initiative, Making Care Primary. And that's an initiative that's about a 10.5-year initiative. Medicare is the large focus. It's not necessarily focused on Medicaid, but from our perspective, that's okay because providers know Medicaid. They understand the payment rates are a little bit better compared in the state, and that they understand sort of Medicare as a vehicle and some of the value-based payment structures that occur. So we have more interest in the Making Care Primary from providers and different payer groups. And what we like about the model is it's a really thoughtful model. It talks about building primary care practices up to a current fee-for-service, to how do you perform the best and highest work as a team within that primary care health home that moves from fee-for-service to a prospective payment model that allows that extra funding for the things that FQHCs can do, unlike private practices now, in part because of the way they're reimbursed. So it's a long time frame, but it's thoughtful, and it actually has a chance of being successful. So we're going to be engaging in that. There is a call for people interested in October. And I think that the other piece is we have to help both, I think, the public understand, but also I think it's my job, our job, to help the governor and the legislature understand the importance of primary care. And I'm not honestly sure we've been able to articulate in that in a way that they understand. So I think, yes, we need to fund primary care at a much higher level. It's foundational to, I think, the health of our health system, as it were. And I think we have to help people understand the importance of it. So I'm not really answering your question, but I think we need to continue to work on that. We are doing some things, but it's not enough. We can always do and need to do more. Yeah.
Great. Well, thank you so much for joining us. Thank you, Dr. Fotinos, for your closing comments and wrap up and reminding us to look for the solutions and the optimism. Thank you all. Thank you to our sponsors, particularly AmeriGroup, for helping us here today. Thank you all for the engagement throughout the day. It has been just wonderful to come together to talk about the issues in Inland Northwest. And I really do appreciate it, and I wish you all safe travels back home and get a brownie on your way out. Terrific. Thanks so much, everybody.